We're in the nice position of starting our plenary a few minutes early, so we will have probably more time for discussion of what I think is going to be a really fascinating topic. At least it is for me, as I was on the spear point of quality metrics in the latter part of my career. It's with great pleasure that I introduce Julie Schuller, who is the Executive Vice President and Vice President for Clinical Affairs at 16th Street Community Health Centers. Julie holds an MD, an MPH, and an MBA, and so she has a phenomenal background in training and experience. And her experience relative to this particular topic extends not only from clinical care, but also to the fact that she sits on the board of directors of the Wisconsin Collaborative for Health Quality, WCHQ. Those of you who are clinicians know it as the publicly reported quality metrics standards for Wisconsin. And many organizations in the state are voluntarily reporting their results on the WCHQ website. She also sits on the Aurora Quality Committee as the kind of a community representative or liaison. So she has a broad view of quality metrics in Wisconsin, and I hope this talk will stimulate a robust discussion about the current state of quality metrics and where we think it might go in the future. In particular, ask yourselves, is there a role for RIN research in developing quality metrics that are important for patients? So I'd like to introduce Julie.
Good morning, everybody. Thank you for having me. It's a pleasure to be here. When David invited me to speak, the idea was to help to stimulate some ideas for the World Cafe that'll follow this. And so hopefully my goal in the presentation is to be not to be provocative to the sense of trying to stimulate ideas and thoughts about quality metrics and what's the current state right now, what are the gaps, what are the problems or challenges or issues, and so really trying to give you a potpourri of ideas to stimulate thoughts for the next conversation around the World Cafe. I don't know that I have answers, but really the goal is just to begin a conversation around quality metrics. So that's what I hope to do in the next 30 minutes or so. And so I think quality is such a big, broad topic, and the question is, what does quality mean and to whom? And at least in the healthcare environment, there's lots of sort of stakeholders. There's clinicians, there's patients, administrators, and a host of others that are looking at quality probably from very different lenses. And so the metrics that have been built over the years do a better or worse job for each of those stakeholder groups. When you think about patients, things that might interest patients would be around whether the healthcare staff listens to you, whether they're friendly to you, answer your questions. When you think about administrators, they're thinking probably oftentimes about more of the operational issues. How long does it take us to answer the phone, things like that. And so I know lots of the organizations that you all work for have dashboards that look at these sorts of metrics. When you look at clinicians, many of us are interested in particular metrics related to our specialty, comparing ourselves against our colleagues or ourselves against ourselves over time. And so that adds a whole nother host of metrics. But because of all this, the number of metrics that are currently in use are just skyrocketing. And when you look at the number of indicators that are collected for these various organizations, CMS, for example, through PQRS, now that ACO reporting systems, meaningful use metrics, has over 1,700 metrics in use. NQF has over 600. Add in HEDIS, Joint Commission, and when you look at those large number of metrics, how can we all do it all? And how do you make sense out of 2,000 metrics? Which one means something, which one doesn't mean something, and how do you go about providing some focus or where's the value in those metrics? So I think lots of folks believe that at this point we've come to a place where there's just data overload. We're not in a place of focus, and we don't really know which metrics are the ones that are really adding value and which ones are the ones that are cumbersome and not adding value. And lots of folks are realizing that there's an increasing burden along with the measurement. As the number of measures continues to grow without gains in health outcomes, responsibilities for assessing, measuring, and reporting can become a burden without marginal benefit. And I quoted this Health Affairs article a couple times. It's a good article about the issue if anyone's interested to pull that one up. So we're looking at where's the focus, where's the interrelationship between all of these metrics, and where's a parsimonious set of data metrics that has value. So when you talk about investing QI resources, most of us have only a certain pot of money that we can use to invest in our QI. The need to invest in capturing required metrics and to improve performance on these metrics to reach the top echelon has caused some providers to overuse measurement resources and improvement dollars in these high-profile metrics that are being publicly reported. But that depletes those measurement resources for important measurement topics or also for other initiatives that healthcare systems may be of more value to healthcare systems, but they're so focused on QI metrics that they're not able to get to those other areas that need value. This is another paper that I think was really interesting from the BMJ, British Medical Journal of Quality and Safety. And it describes Massachusetts General, which is, of course, we know one of the preeminent hospitals in the country, reporting on so many quality measures that they were unable to invest in other patient services programs that they wanted to because they had invested so much in their quality metrics. So when you spend on quality, and especially metrics that maybe don't matter, you're trading off against other activities. And so as long as you're aware of the trade-off, that might be good, but I'm not sure that we're all aware of what are we trading off for building these cumbersome reporting systems. And are we making conscious decisions about what we're trading off? Additionally, flexibility of resources. So when you have a data set and providers are asked to perform to that data set, it might not be applicable to some providers. And so is a smaller data set better, or is a broader data set better? Is it better to have a core set where you can do add-ons for particular things that are of interest to your particular area of work? A broader set, a broader optional set and a narrower required set may alleviate the problems of diverting money to things that really aren't of interest to you but show up on the metrics list, especially when they're publicly reported metric lists. So current challenges around measurement, I've listed them in three sort of categories. Challenges related to the measures themselves, challenges related to data, and challenges related to the public reporting that goes along with all of this. In terms of the measures themselves, there's a lack of standardization and comparability from one reporting body to another. I'm sure many of you are familiar with this. For example, going to measure control of diabetes. What's the numerator in that equation, what's the denominator in that equation, and oftentimes they're different across reporting bodies. So for WCHQ it might be one thing, for PQRS it might be another, and for some other particular reporting body it might be a third way of reporting that. That lack of consistency and standardization makes it very difficult to compare across reporting tools. A second challenge is that when you set out a measure, this can lead to methods that technically meet a requirement but don't really add value. So some organizations may initiate an activity to meet the measure, but did that activity really add any value to the care being provided? One example that I've heard of is a hospital system that, in order to meet the requirement around smoking cessation and providing counseling to smoking cessation, the easiest time for them to do that was in the middle of the night. And so they passed out a pamphlet to each patient that smoked, put it on their bedside in the middle of the night. Well, they got to 100% that they met that metric. Every patient got smoking cessation information. But it was in the middle of the night, and so did it really help anything? They met the metric, yes, but did it really add any value to those patients? Obviously, that answer is no. There's a lot of questions around process measures and outcome measures, so folks know that process measures are measures that identify whether you did something along the way in the process. So again, for diabetes, how many hemoglobin A1Cs were tested during the year? Versus outcome measures, what was the patient's diabetes control like? Or even better, what was their quality of life like? And so there's a lot of question on whether those process measures really impact the outcomes or not. And there's data on many measures to say that it probably doesn't, that the process measure doesn't really impact the outcome. And then as we've burgeoned all these data elements, when is it time to eliminate data elements? There's not been many in the past few years that I can recall that have been eliminated, but they've grown and grown and grown. I will say that one that we've eliminated, and I think some reporting bodies have eliminated, is did you check the BMI? And because everyone was getting to 100% on that. So yeah, we checked it, but then now it's added, did you counsel on that? And I think that gets more at the outcome, but not all the way there. So the question of when to eliminate measures, I think, is a good one. And are we doing that often enough? Additional challenges in measurement. I mentioned the lack of, this slide is to demonstrate another indicator where there's a lack of association between the process measure and the outcome measure. And this study that I referenced looked at the HEDIS measure of asthma medication management and whether a controller medication was prescribed and adhered to. And they divided the results into quartiles. Over 75% of the time it was, 50 to 74% of the time, and under 50% of the time. And what they found was there was actually no difference in the outcome related to hospitalizations, ED visits, and rescue inhaler dispensing. So that process metric did not impact the outcome for the patient. And so is it really of value to be measuring that metric? And how much are we investing both in time, money, and other resources to collect that metric? And if it doesn't make a difference, why are we doing that? Additional challenges related to measures. Specialist measures are sparse. There's many more specialists than there are generalists, but many specialties don't have a core set of metrics. And the question is, should they, and what are they? And as we build those metrics, are we mindful of these issues that have already been brought up in terms of over-measurement or what really matters? So as we develop the specialist metrics, be cognizant of all these other issues. What about metrics related to overuse? We know that there is many of the metrics that we follow, pap smears, mammograms, colorectal screening, are underuse metrics. What about overuse metrics? We know some of them, overuse of antibiotics for ear infections, for example. But there are many other areas where we overuse tests and procedures, and what metrics belong in our metric set for that. Attribution methodologies get a lot of scrutiny, and so if in large databases, which patient is really my patient? How many times do I need to see that patient for them to be considered my patient? And my personal pet peeve with the Medicaid HMOs, I don't know if there's anyone in the room, is when they think someone's my patient, but I've never seen them before. And so they're creating a data set on my patients, and I don't call them my patients, but they call them my patients. And so I think attribution methods need some looking at in terms of where the value lies there. Do current measures reflect more of the interests of the providers or the patients? Are we leaned too far towards providers? What is of interest to the patients, and are we sure we're capturing those things? I have some more slides later on about patient-reported outcomes, and I think those might be outcomes more important to patients, along with some of the patient satisfaction data, than some of the metrics we're reporting now. And then measures keeping up with changes in clinical practice and the accompanying burden that comes along with those changes. So you all know how the standards regarding pap smears have changed over the past 5 years, probably 2 or 3 or 4 times. And keeping up the behind-the-scenes methods in your database to track those changes is cumbersome and oftentimes difficult to get a reliable number in that metric field. So I think it's a challenge to keep up with those changes as they come along. In terms of moving from sort of the particular metric level to the big data level, all of this data collection requires significant investments in technology, processes, people to collect and organize the data in a way that is meaningful. There's geographic variation in terms of the capabilities and resources that different areas of the country have to invest and implement large databases. And methods to move data into a database where comparison across providers can be made. That has its challenges as you take data from diverse databases and try and put it into one to create a meaningful comparison. In terms of public reporting, to date there's not been a lot of activity around patient experience or particularly patient-reported outcomes in public reporting data. The user-friendly interfaces have been difficult. I think there's been a lot of good progress in that area, but I think getting data in a format that the general public can understand and use to make decisions has been a challenge, even for people who have a good health literacy competence. And for those that don't, I think it's been an even tougher challenge, and my personal opinion is we're not there yet. And then specialty metrics being publicly reported. There's not many out there publicly reported yet. WCHQ, as David mentioned, I'm on that board. We're looking at what specialties to begin to do some public reporting with. It tends to bring up a lot of discussion, healthy discussion, and some controversy, and that's good, I think. But so we're not there with specialties in being publicly reported yet. So I think the challenge is, what are the metrics that really matter? And which of the hundreds or thousands of existing indicators will really result in changes in care and therefore result in changes in health and the greatest improvements in health? not only that, can we quantify then those gains so we're knowing from a research basis that we've made those gains, or is it more of a qualitative sense? But which indicators have the greatest potential to have a positive effect on the health and well-being of individuals? That's the question. The Health Affairs article I referenced looked at the issue in terms of a set of 13 indicators that have been core indicators, and 7 of those 13 accounted for 93% of health improvements, but 6 of those 13 accounted for only 7%. And so is it even valuable to measure those 6, and what do we do about this situation? So in this article, what the authors did was they sought to quantify the population health gains that are expected from improvements in particular indicators, and also took in costs, and they came up with an equation to determine a number or a value, and they called that the expected population value of quality indicator reporting. And when they did that, applied that value to those 13 indicators, this is the results that they came up with. Earlier study, this study was done in 2013, but way back, if you look way back to 1996, there's another study that looked at the costs and benefits of 185 interventions in the U.S. that were designed to reduce premature mortality. And they found that the U.S. spent $21 billion on interventions that prevented 56,000 deaths. However, if those same dollars had been invested in more cost-effective interventions, there would have been 60,000 additional deaths on top of that prevented. So the question is, or the issue is, how do we identify those metrics that really have value and then use that information ongoing into the future? And it's interesting to me because I didn't even know about any of these studies until I started looking into it, and it makes you think, well, why didn't we pay more attention to that and make some changes? I mean, 1996 is a long time ago now. So is it time to provide some guidance and principles for the development of quality metrics? And there are several groups that have done that, and so I wanted to show you what other groups who've thought about this, what kinds of guidance and principles that they've developed. This is from the group that wrote the article in the BMJ Quality and Safety Journal. It's written by folks from Dartmouth, Ascension Health, Intermountain Healthcare in Colorado, Mayo Clinic, Kaiser Permanente, Institute for Healthcare Improvement, and others. So those are big names in quality, as you know. And these are the guiding principles that they felt were important for development of quality metrics. Measure process outcomes only if they're tied to real outcomes. Don't measure process just to measure process. Measure the actual outcome metrics, as well as patient experience and total cost. Design data systems to collect data and build quality measures into the workflows. And for key processes, design the data system around the workflow. Don't design the workflow and kind of go back and retrofit the data system. And provide transparent reporting to promote learning, healthy competition, and public accountability. Use return on measure investment analysis so that you actually know if that metric is making a difference. And cost of measurement relative to impact on outcomes and cost. So what is it costing to do the metric, track the metric, report on the metric, and is that cost worth the value that you're getting out of that metric? And then establishing an ongoing process for refining and selecting new measures, and I would add, and then eliminating old ones as it's time for them to fall off. AHIP, I'll talk about them in a minute and who they are, but it's another group that's working on quality metrics nationally. And this is the rules that they created for a good metrics set. Measure sets must be aimed at achieving the 3 parts of the triple aim: better care, healthier people, and more affordable care. They prefer NQF endorsed measures. Now, I'll put a little parentheses. These are folks that work a lot with the NQF or are part of it, so they preferred their own measures, which may make sense. Data collection and reporting burden must be minimal. Overuse and underuse measures should be included. Measure sets for clinicians should be limited to fewer than 15 measures when possible. Measures that are currently in use by physicians measure patient outcomes and have the ability to drive improvement and are preferred. The measures are cross-cutting across multiple conditions to reflect a domain of quality like patient experience, patient safety, etc. Measures should be meaningful to and usable by consumers and also applicable to different patient populations. Patient outcome measures should allow careful and prudent physicians to attain success. They shouldn't be measures that are so unattainable that people aren't engaged in attaining those measures. And as with all measures, those which reform payment or delivery systems should measure clinical quality, patient experience, and costs, kind of a repeat of number 1. This I put in because I wanted to, again, emphasize, should we do some metrics for overuse of testing? So Choosing Wisely, I think people know, is an organization that was designed to look at what tests are we overusing. They have a lot of materials and research and sort of collected best practices from specialty societies on what tests are overuse tests and in what situations. They have literally hundreds of situations where there is potential for overuse. And their website is really nice because it's got a clinicians and a patients section, and so you can go onto their website and look at whatever condition you might be being treated for or that you're a physician treating and see what are the overuse scenarios for that particular condition. I think it's a really nice website, really nice organization looking at what I think is an important issue. But they want to choose care that's supported by evidence, not duplicated by other tests, free from harm and truly necessary. And so the question is, how do we start to incorporate some of these overuse patterns into our metric sets? Moving on to an area of patient-reported outcome measures. The PROM or PROM as different from PREM, which is patient-reported experience measures, like some of the issues that come on patient satisfaction surveys. But PROM, patient-reported outcome measures, these are the patient's view of their symptoms, of their functional status, of their quality of life. They're not necessarily outcome measures per se, because they're sort of a point-in-time measure of a patient's health status. And the outcome really is if you were able to track that measure over time. Did their health get better? Did it get worse? So they're sort of health measures, but you could think of them as outcome measures as well. There's 2 types. There's disease-specific patient-reported outcome measures, and there's generic, and I'll show you those on the next couple of slides. The disease-specific ones focus on symptoms and impact on function of a specific condition, and the general ones, the generic ones focus on general issues such as ability to perform activities of daily living, mobility, things like that cross diseases. When you look at patient-reported outcome measures, they've been shown to have as much reliability as some of the clinical measures that we're using, such as diastolic blood pressure readings and blood glucose measurements. So they are reliable measures. But there's not a lot of research out there on patient-reported outcome measures, particularly around their impact and how they can impact care. But the advantages are most healthcare aims to reduce symptoms, minimize disability, and improve quality of life. And these are aspects that really only the patient can assess for themselves. And metrics we impose from the outside of the patient don't get 100% at how the patient is feeling related to their symptoms. And so these are measure sets that actually get at the patient's view of their care and their well-being. Patients welcome being involved, and sometimes being involved with these measures actually improves their response to the treatments that they're receiving, may have health benefits in and of itself. Patient response rates are invariably better than clinicians' response rates. These metrics avoid observer bias, so if you ask clinicians to assess their own practice, they're going to assess it. They have a little bit of a bias in the way they might answer that. And considering patient views increases public accountability. These are an example of disease-specific patient-reported outcomes. So in terms of hip score, you can use these for people with osteoarthritis or other hip conditions, as well as postoperatively for hip surgery. But questions about patients' functional status and symptom status related to their hips. These are generic questions for the generic piece of it, and looking at sort of self-care or anxiety and depression questions in terms of what are the patient's symptoms in those areas. So the uses of these measures, they can assist clinicians to provide better and more patient-centered care. So the way that would be used is clinicians get the real-time feedback from the patient through some sort of data tool on how they're doing. So if a physician sees a patient once a month, in between those visits, they maybe weekly could get a report of the hip score on a patient with hip osteoarthritis, and that could potentially help to determine when's the right time for surgery, or when is it time to change a medication, or things like that. They can be used to assess and compare the quality of providers and provide data for evaluating practices and policies. In terms of the data, if you can bring this to a scale that's big enough, you can have large numbers of patients within that data set, and so it allows for a robust comparison because of the large numbers. Some of the challenges: time and cost of collection, analysis, and presentation of this data. Getting patients to do it can be challenging. Attributing outcomes to the quality of care, so patient's hip may feel better, but it might be related to other things that are going on in that patient's life rather than the actual care that the provider is providing. Providing appropriate output to different audiences, so what does the patient want to see from that tool? What does the physician want to see? What does the sort of public reporting potentially want to see? And how do you adjust that output for these various audiences? And then avoiding misuse and for reasons that they're not intended. So as far as patient-reported outcomes, what's next on the horizon in terms of building this toolkit for healthcare practice? Currently, they tend to be either used clinically or for provider comparison, and there's not a lot of joint use. So combining the initiatives to use them more together rather than the separate paths that they're currently on. Encourage adoption of new data collection technologies to make it a part of everyday life. So some of the apps or the Fitbits or those sorts of things, and how do we interface that with the clinician in their daily practice. Priority disease and treatments, which ones are the ones that this works for and which ones are the ones that maybe it doesn't matter so much. There are methodologic challenges to this kind of data. And then how do we use them in value-based care? How would we arrange payment systems around these kinds of indicators? That really is an area that hasn't been much touched. Switching a little bit to metrics and how do we, this is not just patient-reported metrics, but all metrics. How do we look at them ongoing over time? And how do we decide when is the time that a certain metric is no longer needed? So it might be time to retire a metric when the evidence basis for a measure has changed, when we've topped out on performance and everybody's at 100%, and so is there really a reason to keep measuring that metric? When the cost of collecting and measuring the metric outweigh the actual utility of it, and when it's demonstrated to have minimal impact on health outcomes. Those would be reasons for retiring a metric. But have we done this on a routine scale so we know which ones they are? I don't think so. So, I mean, there might be room for looking at particular metrics and saying, is this metric need to be retired? And even metric sets, which ones need to be retired and which ones should be continued. This is, how do you know good care when you see it? This is getting at some of the nuances of metrics in terms of beyond just the objective, did you have a mammogram or not? What are the pieces of good care that you and I can all recognize, but maybe aren't being reported right now? And so this is, I want to talk about a study that was done by Rebecca Etz, and it's actually from the anthropology circles, and she asked 2 questions, and I think several of you all in the room participated in answering those questions, more than several, 20-some people. So she asked a broad group of people, including bloggers and Twitter feed people, and you can tell I don't use Twitter, but I don't know what you call it, and research networks and things like that, and primary care groups to get answers to this question. And the questions that she asked were, how do you know good care when you see it? List what you think are the top 3 to 5 qualities, capacities, or characteristics. And if allowed only 5 questions, what would you ask members of a practice to know if they are helping to deliver health and wellness to their patients? And she categorized the responses into several areas and built these trees around them. And what you can see is that a lot of the answers aren't what we're currently measuring. And so is there room to develop measures around these kinds of issues that might add more value to the metrics we're currently reporting? Access, visits, characteristics of visits, of follow-up, and around relationships, people's relationship to their provider, to their clinic, and then place. What's the practice culture? How does it fit into the community? I want to just mention briefly, because I'm running short on time, the current state, and we won't go through these in detail, but there's a lot of groups that continue to work on building metric sets and augmenting metric sets. And the Center for Healthcare Transparency, AHIP, and MACRA, which is the new law that came out of the SGR fix, they're all continuing to build more and more metric sets. The IOM core metrics paper was really of interest to me. I was excited to see it because it talks about just this issue we're talking about and the burden of metrics and are we measuring the right thing. And so they had a work group that was set out to study the current state of measurement and identify measures that are most reliable. And what they came up with was this measure set, which is different than the measures we're using, and I think intriguing in that it's very cross-disease oriented and almost a little public health oriented. So it's very high level, and to me I think it's a very good way to think broadly of it, but I wonder if people aren't going to be tempted to start to throw in those individual metrics under these, and maybe that's a good thing. But how you get at some of these issues or these metrics, I think, is a whole process of how do you get to childhood asthma, which are the metrics for childhood asthma, et cetera. But I liked this framework for taking a step back and trying to think what's really important from a broad-based level. The Center for Healthcare Transparency is another group that's working on another set of metrics, or not another, but a set of metrics. And they actually are based out of Houston. They're funded by a foundation out of Houston, and that group is looking at really impacting how patients make choices and how purchasers purchase healthcare, and whether they're getting the most value for their purchase. And they've developed some measure sets that I've listed here: patient-generated metrics, clinical metrics, and then cost and utilization metrics that they believe are important for changing healthcare. AHIP is in the process of developing a set of metrics. This is a group that has at least a portion of it coming out of CMS and NQF, as well as the America's Health Insurance Plans, which is the trade association for some insurers. And they're in the process of continuing to develop a metric set. They're very focused on specialty sets and have some engagement from the specialty societies around developing sets within their specialties. Their goals, as they look at it, is to reduce the total number of measures by eliminating low-value measures and introducing consistency, refining the measures that remain to ease the burden of collection, and relating measures to patient health outcomes, focusing on measures that matter. And then, of course, macro was just introduced. We're still in the public comment period, but it's the law that's called the SGR fix, and it combines all of the CMS quality reporting programs into one system where people can either choose the MIPS or the APM. And it's very, very complex and new still in that the final regulations haven't been released, but it's going to take all of the CMS data reporting and combine it into one system. So they're going through a process of trying to figure out which metrics will be incorporated into the MIPS and which ones won't. Final two slides. What are the gaps currently? As I've looked at this, I think I don't know that I have them all captured, but these are my thoughts on where our gaps currently. Patient-reported outcomes seems to be in its infancy and something that maybe we could consider as a country in terms of something helpful to the metrics. Social determinants of health is something near and dear to my heart, and both developing systems to capture social determinants, working on improving the social determinants so we can improve healthcare, but then also risk adjusting if we're paying people based on outcomes, and we're treating different socioeconomic groups, ones that might have more difficulty attaining good health. How do we risk adjust our metric sets for those social determinants? Specialty measurements, so measurements around specialty care, patient and community engagement measurements, which I think is a gap right now. Composite indicators, and that's what the IOM was getting at a lot with the set they proposed. The composites that work into patient safety or healthy communities or evidence-based care. And then the last gap is process for metric elimination, and how do we know when to get rid of a metric. So where do we go from here? Fill in the gaps, develop a smaller measure set that really has value, measures that matter. Identify which metrics contribute to value and result in change that can produce the greatest improvements in healthcare. Broaden the measure set as needed for a very specific QI reason. And then agree on guidance or criteria for good metrics. I listed a couple groups' ideas on that. You can see that there are a lot of similarities, and can we get to a place where everyone has the same criteria? And then the final question, what do we do in the meantime? So we know we have these issues and these problems with the reporting systems now. Do we continue with this do we continue with the way it is, which is, there's a train rolling down the track already. Is there a way we stop doing something while we fix something else? But what do we do in the meantime while we continue to work on these problems around the metrics that we're currently collecting? So hopefully that stimulated some thoughts and ideas as we roll into Ren's research agenda. But we have time for questions or discussion.
We have time for questions, so we'll keep it open for another 10 minutes or so, and then before we break, I'm going to come up and say a couple words.
Hi, David Feldstein from Madison. So what I found, I have to say, concerning in everything about, except for the IOM, was that there was nothing about that the care matches the patient's goals. And so what happens, we know that when we measure metrics, and especially when we tie pay to it, we're going to change care. But are we changing care for what the patients want, or are we just changing care for what we think we should measure? And we've talked a lot about shared decision-making over the course of this conference, and that doesn't seem like that fits anywhere in our metrics, and that's certainly a concern. I was wondering what your thoughts are.
Yeah, I agree 100%, and it probably belongs in that gap section, so that's a gap, and how do we go about closing that gap, getting patient input on the metrics? And I think that probably involves patient education on the metrics, which may float out of some of the public reporting tools that may or may not flow out of some of the public reporting tools as patients get more familiar with metrics that are currently in use. Hopefully they'll become more able to provide feedback on what's helpful and not helpful.
Well, I would say that it's even a little bit more than that, because it's not just them knowing the metric. Actually, we shouldn't care if they know the metric. We should care that they know what the risks and benefits are and what they want. Our metrics should be able to obviously account for that, because that is our goal. Our goal is to give the patients the care that they want and the best care for them, not the best care for our entire population. And these metrics drive us towards treating the entire population the same way, even if it's not what that individual patient wants.
Agreed.
Andy Wright from Richland Center, and I thought it was a very good overview and gave me a lot of information as the sort of the QA person at our rural clinic. There seems, just to sort of dovetail on what David was saying, and maybe this isn't the right thing to say, but there seems to be a tension, right? So if a patient says that their outcome is they enjoy their smoking, but I know their smoking's hurting them, then I'm not necessarily totally interested in that patient's outcome. At the same time, I recognize that health is a bigger concept of feeling well, and so I think we do agree to some degree that we have to have some objective measures. We have to have somewhere to hang our hat, and yet I feel that tension. I always want to do shared decision making, and yet I have this tension from insurance companies to meet certain metrics. And at the same time, I have deep held beliefs. I think obesity is harmful. I think smoking is harmful. That's part of medicine, right? So I guess that's just a comment. The other one, somewhat unrelated, but also addressing that tension, is we have insurance companies that say get your A1C under 8 or 7, but really we know it's different for different people, right? The Choose Wisely American Geriatric Society says, hey, you've got a frail elderly person, keep it between 7.5 and 9. And so I guess me as a clinician, I've chosen really to ignore this payment. I mean, why would I want to go for that payment when it's not helpful for my patient? And so I think to some degree as clinicians we have to ignore the incentive if the incentive is misplaced.
Julie, I want to thank you for a great presentation. My name is Al Musa from Madison. I don't even know where to start with a question because this is a great lead-in to what we need to discuss next. It's been interesting to me how much of the research has devoted conference healthcare transformation has snuck into our agenda. I right now have the privilege of being in a curriculum at Dartmouth, and the issue that I've become very aware of is values in the eye of the beholder. So the challenge, to quote Elliot Fisher, is we have a cacophony of measures now. So I don't want this to be totally a commercial for the IOM outcomes, but I think it does blend community, the business models that organizations live in, and payment reform. And so it gives us a great opportunity to structure from there. And for Ren to take what comparative effectiveness research do we need to accomplish to contribute to those. Trying to turn that into a question, my challenge is, I guess my question would be, what's your best view of, we can't let one group own this, so the payment reform part is driving this now. That's okay, but how do we get the organizational survival, even at a practitioner level, right? And the community, the patient value-based part. So how do we represent value in all three of those spheres? What's your best prediction or goal?
Well, I don't pretend to be the expert, so you guys all are and I appreciate everybody's ideas and thoughts, but again, and I answered the first question this way, as you look at all that's out there on the internet related to these, I just think there's not enough familiarity with the tools that exist for the general public. So that Choosing Wisely site is wonderful, but does a person with low back pain go on there and learn that you don't need a CT scan? Not really. Or do they learn you're not supposed to get antibiotics for an ear infection, but yet they're sitting in front of us demanding the antibiotics? So to me, there's a piece of public education that needs to get rolled into that maybe you'll get to more of us having influence on the metrics that IOM or NQF or others are developing. We have time for a couple more, I think, right? Is it?
That was a delightful subject. It seems as though there's a bottleneck involved in smaller clinics whereby their budget and resources allocated towards measuring things are taken up by trying to meet whatever arbitrary standard is being put out by whoever is paying some of their bills. So do you have any sort of ideas about how we might go about, as a PBRN, trying to take some of the power away from that? How do we get to a point where doctors aren't deciding what sort of measurements are important? Rather, it seems a lot of decisions are made by accountants that don't really know what's going on. What kind of ideas do you have about that?
I wonder if some of the really broad cross-disease metrics, like some of them on here, if you're aiming to get at quality of life, for example, what you decide to do in a smaller clinic setting could potentially impact that, but you could have some choice in how you're going to get there. So for your community or your practice location, maybe smoking is a huge issue, whereas in another community it might not be at all. So I guess what I'm saying is maybe if we have broader based metrics rather than the very specific metrics that we have now, that would allow for some creativity and flexibility in how do you get there. Just a thought.
Hi, Jonas Lee from
One
Madison.
more question,
Wisconsin.
and then we'll go on. Go ahead.
That was wonderful to hear. It's nice to see that we're kind of on the far end, hopefully, of where like this measurement craziness has taken us. I quickly looked up this the study that you mentioned, How Do You Know Good Care When You See It? And I would really love to see that reproduced from a patient perspective. So it looked like that was primarily primary care providers. It'd be interesting to see it from a patient care or patient perspective and see how those two fit together or don't fit together. Along the lines of what you were bringing up, David, like how do we take both of those aspects when what a patient wants might not necessarily look like what's the best medical care, and there still seems to be a gap there. And then to thinking about yesterday, there was a kind of a robust discussion around palliative care, and I'm thinking, well, all care that we provide is actually, or chronic care is kind of palliative care anyhow. Everyone's going to go out. And thinking about those interesting models where, with the palliative care model, how they've gotten these remarkable outcomes when they're really focusing on patients, and yet they get better survival times than standard care. So maybe listening to what the patient has to say and meeting their goals is going to be a better way to go, and making sure that we include them in the process.
I think those are good ideas. This is one of the graphs that came from that study. And when you look at some of these metrics, they're not at all what we measure. And so I think that's good food for thought on what are the right metrics to measure. And getting a schematic like this for what patients respond would be really interesting and helpful.
This is not the end of the discussion. I hope this is just the beginning of a discussion. I'm really thrilled to have the kinds of feedback we've been having. Don't get up yet. There's a couple of things before the break, but after the break, we're going to have our World Cafe, where I hope this kind of discussion continues. My personal view, bias, is that quality metrics drive a lot of what we do, both for good and ill, and this is a rich opportunity for Ren to contribute to the kinds of filling the gaps that need to be filled.